Our next speaker is Dr. Derek Robinson, a Vice President and Chief Medical Officer of Blue Cross Blue Shield of Illinois. Dr. Robinson will share with us how structural racism impacts a number of the social determinants of health and health care. He will also share some efforts underway at Blue Cross and Blue Shield of Illinois to improve social determinants of health at the local level. Derek?
Thank you so much for the opportunity to be with you all today. I'm going to take a few minutes to build on the foundation of information shared by Dr. Jones and to really do so with a local view. Let me start off by talking about one of the challenges that we face in Chicago and also in the state of Illinois. In Chicago, we have the unfortunate distinction of having the largest life expectancy gap between neighborhoods, which is the largest gap of any city in the United States. And because when we talk about health, it's important to also understand that because we have challenges in terms of historical segregation and housing both in the city of Chicago and cities across America, often we begin to see health factors correlate with race as well. When you look at this slide here, it reflects where populations lived in the city of Chicago back in the 1960s. And we know that place and race in our city, as well as in many other cities across the nation, have a close correlation with historic policies that were actually racist in intent and in impact. And we know that many of those policies and intent that was codified in law has changed now, but we also recognize that the long arch of those policies extend from the 20th century even into the 21st century. So the map that I just showed in blue was where white Chicagoans lived back in 1960, and in red is where you see predominantly African-American populations in the city. When you look at this slide from 2010, you'll see that some things have changed and some things have remained the same. A lot of the pink distribution is where white citizens of the city live. The orange represents where the Latinx or Hispanic population is, and then you see the African-American population in blue, again, on the south and west sides of the city. Now, the next probably 10 slides I'm going to flip through are going to move through them pretty quickly. The point that I want to make is really a pattern, which really shows that as we begin to look at major indicators of health status, we see a strong correlation between place and poor health. And here we see a map that also shows place and race. And so this gives us a chance to see longitudinally how the impact of policies and decisions put in place, many years ago, 100 years ago, still are having impact on the health of African Americans and other populations across the city. So this is more of a composite measure that looks at economic hardship. Again, you see that these are predominantly neighborhoods around the city on the south and west side. Our next slide looks at children that have low childhood opportunity. Again, you see that in the same neighborhoods. These are predominantly African American and Hispanic neighborhoods. Again, as we look at environmental quality, these are where we have children who have high levels of lead in their blood, which we know contributes to cognitive delay and behavioral disorders. Again, the same geographic distribution. When we evaluate unemployment, similar pattern. When we look at life expectancy, which we started off our conversation with, again, lower life expectancy in these communities. And then when we look at educational attainment, individuals that are adults who do not have a high school diploma, again, we see that in the same geographic distribution. And then finally, when we look at violence, we see a high distribution of violence in some of these same communities on the south and west side of the city. I added an additional slide in here just for context around infant mortality, because that is something that is really heartbreaking, and we see it substantially, disproportionately affect African-American community. And the next slide shows it even better. You'll see in the gold graph, the African-American infant mortality rate is multiples that of the white infant mortality rate, which is in blue on this slide. So we now begin to tie some of this impact to also looking at wealth and income. This data I pulled from a report from the Chicago Community Trust. You see for every $100 of wealth that we have, and with white families in Chicago, black families have about $10. And so we really see that come into effect as we look at the financial resiliency of families today dealing with COVID. Now I want to pivot just back to the housing thing. So we talked about the historic impact of discrimination in housing, which is codified in law, and many of those policies don't exist today, yet we see that this analysis, which was done by WBEZ and published on June 3rd, shows how banks lend money for residential properties in the city of Chicago. And this looks at from 2012 to 2018, about $57 billion allocated for residential loans, but you see that those are predominantly in the non-black, non-Hispanic communities. In fact, for every $1 that was invested in white neighborhoods, 12 cents was invested in black neighborhoods. So that causes us to ask the question, what's the impact of what policies that are in place today that impact lending? So I'm going to switch over and talk just a little bit about healthcare. Again, this last slide just notes that we in Chicago have the largest economic mobility gap of any city in the nation. The famous quote from Dr. Martin Luther King regarding inequality and the fact that injustice in health is the most shocking and the most inhumane because it often results in physical death. And he actually made that quote in Chicago in 1966. Many of you who are familiar with major healthcare reports know that we've had some landmark reports that have pointed to discrimination in actual delivery of healthcare, and that patients are treated differently based on their race and ethnicity. And so part of what we're trying to do is take some actions based on the information that we are aware of today. We know that health disparities cause an additional $100 billion in excess direct medical costs each year. As a health plan in the state of Illinois, we spend over $25 billion on health care services for our members. We are rapidly moving down the value-based care pathway. We have about a third of our membership in value-based care programs and over a third of our spending there. So one of the things that we've done is figured out how do we begin to align the imperative to eliminate health disparities in our value-based care programs as they move forward. In 2019, we rolled out a training requirement for our physician groups. We have about 80 IPAs that support our more than 600,000 members in our large HMO product, where we created incentives for providers to participate in training on implicit bias and cultural competency. We then rolled this requirement out to our accountable care organizations who were involved in incentivized training this year. In subsequent years, we also asked these groups to stratify their quality data by race, ethnicity, and language, and then to focus on reduction and elimination in disparities, particularly in asthma, diabetes, and hypertension in outlying years. And so we're beginning to, again, align these imperatives with financial incentives. We've also partnered with the American Hospital Association to help incentivize more hospitals participating in the AHA's Health Equity Pledge program. Several weeks ago, we announced 13 awardees for a grant program of over $1 million that would be divided amongst more than 13 hospitals to help support their efforts. We have also partnered with a number of organizations, including the American Heart Association, where we're investing in addressing food insecurity in different parts of the south and west sides of the city. We have an example of two small businesses that have received investments, 40 Acres Fresh Market and the Sweet Potato Patch. We are also in the process of rolling out the Centering Pregnancy Program, which is a program of the Centering Healthcare Institute, which has demonstrated through the evidence-based care model of actually reducing disparities and racial and ethnic disparities in premature deliveries through group prenatal care. And so we're actually helping a number of FQHCs get this program started up in neighborhoods where we see high levels of prematurity. We're also investing in housing programs to help support individuals who have both challenges with homelessness as well as chronic medical conditions to help meet that need, provide wraparound services and housing to help them realize their best potential. Now, one of the last areas I want to note here is that we are working collaboratively with our academic medical centers, teaching hospitals, as well as local and national organizations around improving diversity in the physician workforce. We had our first major convening around this last year and have some exciting programs on the horizon in this particular space. And then finally, in this era of COVID, I think it's important also to note that we recognize that we have many communities that have disparate impact in terms of infection rates, hospitalization, and death rates. We have worked with over 75 community organizations over the last few months, donating over $1.5 million to help address many social determinants. And we've also distributed a number of reusable masks, over 100,000 in these communities. And we've supported initiatives at both the state and the local level to, again, address some significant social challenges facing communities across the state, as well as supporting providers with respirator masks, over 150,000. So appreciate the opportunity to participate in today's panel and look forward to the Q&A.